So this is the outline of our presentation today. Next slide. So as for the first part, I'll be explaining on the some important terminologies. Next slide. So for the first one is lie. Lie is the relationship of the long axis of the fetus to the long axis of the uterus. So there's basically three types of fetal lie, which are longitudinal lie, transverse lie, and oblique lie. So as for longitudinal lie, the long axis of the fetus is aligned to the long axis of the uterus. So in the longitudinal lie, the fetus can be either cephalic or breech, as seen in the first two pictures. So this is the most common lie of fetus. As for transverse lie, the long axis of the fetus is at right angle of the long axis of the uterus. The fetus lies horizontally. And for oblique lie, the long axis of the fetus forms an acute angle to the long axis of the uterus, as seen in the third picture. So this is basically a rare lie of fetus. Next slide. The second terminology is presentation. Uh, this is the part of fetus that presents at the lower pole of uterus, which is the pelvic brim, and the presentation is basically determined by the lie, attitude, and position. So I've mentioned about lie just now, and as for attitude and position, we'll have to wait for a bit. So the first type of fetal presentation is cephalic presentation. This is when the fetal head is present first at the pelvic brim. The presenting part for cephalic presentation, there are four types of presenting part for cephalic presentation. The first one is vertex presentation, when the fetal head is completely flexed. The second one is military presentation, when the fetal head is moderately flexed, or it can also be said as deflexed. The third one is brow presentation. It's when the fetal head is fully flexed, or it's usually said as partially extended head. And the last presentation is face presentation. This is due to the full extension of the fetal head, as seen in the pictures. Next. The second type of presentation is breech presentation. This is when the fetal bottom is present first at the pelvic breech, pelvic brim. So there's three types of breech presentation, each with different presenting parts. So the first one is complete breech. This is when both the fetus legs are flexed at the hip joint and the knee joint. So the buttocks and the feet are the presenting part. Second is the frank breech. This is the most common type of breech presentation, where both the legs are flexed at the hip joint and extended at the knee joint. For this type of breech, the buttocks is the presenting part. And lastly is footling breech. This is an incomplete breech where one or both legs are extended at the hip. The knees and legs are the presenting part. Next slide. Okay. The third type of presentation is shoulder presentation, which is commonly seen in transverse and oblique lie. Shoulder, hand, or elbow is the presenting part. So as seen in the first picture below, that is a shoulder arm presentation. As for compound presentation, it is when an extremity is present together with a major presenting part. As seen in the second picture, the major presenting part is the head, but the hand is present together with the head. So that is a type of compound presentation. Next slide. The third terminology is denominator. Denominator is the bony landmark on the presenting part that is used to denote the position. So, like I've mentioned, there's several presenting parts and each have their denominators. For example, vertex and its denominator is the occiput. Face, its denominator is the mentum. Brow, it's the frontal eminence. Breech, it's the sacrum. Shoulder is the acromion. So, the fourth terminology is position. Position means the relationship of the denominator of the presenting part to the maternal pelvis. So, like for example, we have right occiput anterior (ROA), right mentum posterior (RMP). So, what do each of these words indicate? Right occiput anterior. What do they indicate? So, the first letter indicates the side of which the denominator of the presenting part is facing. So it could be left or right. It's the mother's left or right. For the second letter is the denominator of the presenting part. So it could be the occiput, mentum, or the sacrum. As for the third letter, it is where the presenting part is lying relative to the maternal pelvis. So it could be anterior, posterior, or even transverse. So there's actually a lot more possible positions of the fetus, which I'll show in the second slide. The next slide. So these are some of the possible positions of the fetus. Like I'll just explain the last one. As you can see, it says left sacrum posterior LSP. So this, as you see, the fetus is in breech presentation, which means the denominator is the sacrum. So the sacrum is facing the mother's left, and it is also lying posterior to the maternal pelvis, which is why the position is left sacrum posterior LSP. Next slide. So the fifth terminology is attitude. Attitude is the relationship of the fetal body parts to one another. So for example, the first image, image A, the attitude it is completely flexed, which means which is seen in vertex presentation, where the head of the fetus touches its chest. B, it is the attitude is moderate flexion or deflection. C is partial extension, which is why we have brow presentation. And the last one is D is hyperextension, which is why we have face presentation. As you can see, the occiput of the fetus is touching the upper back. For the next terminology is station. Station is the level of the presenting part in relation to the ischial spine. As you can see the image below, there's a numbering right. So for as for 0, it is the landmark for where the ischial spine is located. And we have negative numberings and positive numberings. So if the head is if the top of the head reaches any of the negative numbers, like example, if it's -2, it means that the fetal head is 2 cm above the ischial spine. If it's +2, it is 2 cm below the ischial spine. Next. And for the last terminology is engagement. So complete engagement, or if you say a fetal head is completely engaged or fully engaged, is when the widest portion of the head has entered the pelvic inlet. So how do we know if the fetus is engaged or not? It is where the number of fifths of head palpable abdominally is used to describe whether the fetus is engaged or not. So if more than 2/5 of fetal is palpable abdominally, for example, if it's 3/5 or 5/5, it means that the head is not engaged yet. Or if the fetal reached station 0, +1, or +2, like I explained in the previous slide, it means that it is completely engaged. Next. Okay, so that's it for my part. The next presenter will continue. Thank you.
Okay, so Assalamualaikum warahmatullahi wabarakatuh and good afternoon everyone. So I'm going to present on the abnormal presentation. Next slide. So first we go to the definition. There is a correction here where malpresentation is a presentation that is not vertex. That is according to the lecture by Prof. Zuki last year, which because it could be cephalic, but if the presentation is face or brow, then it is considered as malpresentation. So there are a few types of malpresentation, which is shoulder presentation, face presentation, brow presentation, and bridge presentation. Next. Okay, so for the diagnosis of malpresentation, this is according to Obstetric Illustrated. First is abdominal examination. For the abdominal examination, a lie other than longitudinal will lead to malpresentation. If the lie is longitudinal, we have to see whether the presentation is either head or bridge. And if the head, we have to see if the head presents the leading part, which is either vertex, face, or brow. For the vagina examination, it is important too because we want to know what is the presenting part. For example, in the bridge presentation, the presenting part, when the anus in presenting part might be mistaken with the mouth in the face presentation, because the mouth may be mistaken for the anus because of edema masking the laxity of the orifice. Same goes to the foot and the fingers, and also for the knee and elbow. The ultrasound is to look for any anomalies presented previous that is undetected and to confirm our diagnosis. So next. Okay, so first we will go to the shoulder presentation. For the shoulder presentation, it occurs as the result of a transverse of where the fetal long axis, it lies perpendicular to that of the maternal long axis. You see the first picture here, you can see that the long axis of the fetal is 90° to the maternal long axis. While for oblique lie, it is when the long axis of the fetus is 45° is close to 45° of the mother of the maternal long axis. The causes of this abdominal presentation include placenta previa, high parity, pelvic tumor, and uterine anomaly. And delay in making the diagnosis will risk for cord prolapse and uterine rupture. So the delivery here should be by cesarean section. Next. Okay, second, we go to the face presentation. For the face presentation, different longitudinal diameter are presented to the pelvis in labor depending on the attitude. What happened in face presentation is that the head is hyperextended. So in a normal presentation, the suboccipitobregmatic and the biparietal diameters are in the same plane. You can see here the suboccipitobregmatic diameter, it is from the lowest point of the posterior part of the occiput to the bregma, but the submental is from the junction of the neck and the chin to the center of the bregma, so that those are in different plane. So in a face presentation, what happens is the submental bregmatic is presented first, followed by the other engaging diameters. So if you the picture above below that shows the pale areas, those are the areas that we engage first, followed by the shaded areas. This is the difference between a normal vertex presentation and a face presentation. Next. Okay, here, if you see the attitude of a well-flexed head, the presenting diameter is the suboccipitobregmatic. And the last one, the hyperextended face presentation, it is the submental bregmatic. However, the measurement of the submental bregmatic 9.5 centimeter is the same to the flex head, which is 9.5 centimeter too. Next. It is crucial to distinguish between chin anterior and chin posterior. This is because in chin anterior, the descent and the descent and delivery of the head may occur, but in chin posterior, the fully extended head, it is blocked by the sacrum. So the chin anterior, in internal rotation, it is able to rotate, but in chin posterior, it is blocked by the sacrum. So in mental anterior, vaginal delivery is possible, but in mental posterior, we have to proceed with cesarean section. So I think that's all. To the next presenter.
Assalamualaikum and good evening everyone. So next type of more presentation is brow presentation. So as you can see in the picture, the presenting part will be the brow. In brow presentation, the fetal head is partially extended with the frontal bone lying at the pelvic brim. And again, the presenting part is the fetal brow between the orbit and bregma, and it occurs as a result of fetal neck extension midway between the hyperextension and flexion. The denominator is the forehead or the brow, and in brow presentation, it has a large presenting diameter, which is mental vertical diameter 13.5 centimeter, and it is actually the largest anteroposterior diameter of the fetal head possible. Therefore, vaginal delivery is impossible. Why? Because largest pelvic diameter is only 12.5 centimeter, and it does have to convert to vertex of face presentation, but it is rare and it may cause abnormal labor progress. In Obstetrics Illustrated also mentioned that brow presentation and shoulder presentation both can cause labor obstructed and also if it is unrecognized. Next slide. Next slide is the breech presentation. Breech presentation is the most commonly encountered more presentation, and it occurs in about 3 to 4% of term pregnancy. Term means 37 weeks of pregnancy, but it is more common at earlier gestation, which it occurs in 25% of cases in less than 30 weeks. And usually it will undergo spontaneous conversion to normal or vertex or cephalic presentation in by 32 to 34 weeks. Yep. So that, don't know. Okay. So, and it becomes a problem if the baby is not cephalic by 37 weeks of gestation or at terms. Okay. Next slide. There are few types of breech presentation, which already have mentioned by the first presenter. So we have French breech presentation, flex breech presentation, and footling breech presentation. For French breech, again, as you can see in the picture, the hip is flexed and the knee is extended. The presenting part will be the buttocks or external genitalia, and it is common in primigravida, and it is least likely to cause cord prolapse. For flex or complete breech, both knee are flexed, and the presenting part will be the external genitalia, buttocks, and 2 feet, and it is common in multigravida. And for footling or incomplete breech, it can be unilateral leg or bilateral leg. Here, both hip and knee are extended, and the presenting part would be the feet, and it is more common to cause cord prolapse as the complication. Move on to the next slide. The causes or predisposing factors for breech presentation, it is classified into 2 factors, which are maternal factors and fetal or placental factors. For maternal factors, breech presentation can occur in the presence of fibroids in the uterus, and if there are any congenital uterine abnormalities, like bicordate uterus or septic uterus, and also if the mother have previous history of uterine surgery like myomectomy. And for fetal or placenta factors, first is prematurity, which becomes the most common cause of breech presentation. This is, as I mentioned, that about 25% of cases of breech presentation occur in less than 30 weeks of gestation. So if there are any delivery before term, the delivery might be complicated with breech presentation. Second is multiple gestation. Next is placenta previa, any fetal abnormalities like anencephaly or hydrocephalus. Fetal neuromuscular condition or any abnormality to the diaper volume, oligo or polyhydramnios. Next slide. So how to diagnose breech presentation? Basically by 3 abdominal examination, vaginal examination, and ultrasound scan. During the abdominal examination, the finding of the lie will be longitudinal. And during palpation, we can feel hard, rounded, bilateral fetal pole at the fundus, which suggestive of the fetal head, and firm lower pole that is suggestive of the fetal breech at the pelvic region. And also, for auscultation, we can feel the fetal heart sound will be best heard above the umbilicus. For vaginal examination, we can feel no in the pelvis, and what we can feel is the soft buttock and heart irregular sacrum, and also can feel presence of feet in the pelvis as presenting part in the case of footling breech. And ultrasound scan can confirm the breech presentation and also can look for any risk factors. It can look for amniotic fluid index, to look for oligo or polyhydramnios, look for placenta site to rule out placenta previa, and also can look for any fetal abnormalities. Okay, next slide. So how to manage? Basically, first we need to confirm the gestation, the weeks, and also the diagnosis. You can add the ultrasound. And second is to choose the best mode of delivery of choice. There are 3: external Catholic version, ECV, elective cesarean section, and also vaginal breech delivery. These 3 will be presented in a little detail by our next presenter. That's all from me. Thank you.
Yeah, Assalamualaikum and good morning, everyone. So I will present about the management of breech presentation. So first, we will continue with external cephalic version. So ECV is a relatively straightforward and safe technique and has been shown to reduce the number of cesarean sections due to breech presentation. So the procedure is performed at or after 37 complete weeks gestation by an experienced obstetrician at or near delivery facilities. So ECV should be performed with a tocolytic as this has been shown to improve the success rate. So for contraindication to ECV, first we have fetal abnormalities, placenta previa, So placenta previa is occur when baby placenta partially or totally covers by mother cervix. So that is oligohydramnios or polyhydramnios. Next, history of antepartum hemorrhage, previous cesarean or myomectomy scar on uterus or multiple gestation. Next. Okay, so this is the procedure. First, the woman is laid flat with a left lateral tilt, having ensured that she has emptied her bladder and is comfortable. Then, with ultrasound guidance, the bridge is elevated from pelvis and one hand is used to manipulate this upward in the direction of a forward roll. So, as we can see on the picture, so while the other hand applies gentle pressure to flex the fetal head and bring it down to the maternal pelvis. Okay, next. Okay, for second one, bridge delivery. An epidural analgesia is not essential, but may be advantageous. It can prevent pushing before full dilatation. There should be an operator experience in delivering bridge babies available in the hospital. Okay, so first, delivery of the buttocks. When the buttocks will become visible and begin to distend the perineum, preparation for the delivery are made. The buttocks will lie in the anterior posterior diameter. So once the anterior buttock is delivered and the anus is seen over the forecheck, an episiotomy can be cut. Next. Okay, for the second part, delivery of legs and lower body. If the legs are flats, they will deliver spontaneously. If it is extended, they may need to be delivered using Pinard's maneuver. This entails using a finger to flex the leg at the knee and then extend at the hip. So as you can see at the picture at the side. So first anteriorly and then posteriorly. With contractions and maternal effort, the lower body will be delivered. Usually a loop of cord is drawn down to measure that it is not too short. Okay, next. Okay, then delivery of the shoulder. As the anterior shoulder rotates into the anterior posterior diameter, the spine or the scapula will become visible. At this point, a finger gently placed above the shoulder will help to deliver the arm. As the posterior arm shoulder reach the pelvic floor, it too will rotate anteriorly. Once the spine becomes visible, delivery of the second arm will follow. Okay, next. Okay, last part is delivery of the head. So the head is delivered using the Morrisson-Smellivac maneuver. The baby lies on the obstetrician arm with downward traction being levered on the head via a finger in the mouth and one on each maxilla, as you can see at the top picture. So delivery occurs with first downward and then upward movement. But if the maneuver proves difficult, forceps need to be applied. An assistant holds the babies for the upward while the forceps are applied in the usual manner. So I already sent the video link in the group. So if you didn't understand, you can see the video. Okay, that's all from me. Thank you.
Finish all presenter? Finish all 5 presenter?
No, we have another two.
Sorry?
Another two presenters. There are two more people.
Your line is cracking.
Ada dua presenter lagi, Doktor.
Ada? Two more.
Dua lagi.
Okay.
Can you guys hear me?
Yes.
Boleh dengar tak?
Yes, yes.
Alright, okay. Okay, my name is Farhana. I'm gonna talk about abnormal. Okay, so as we know from the previous slide, the line of fetus describes the relationship of the fetus to the long axis of the uterus. So if it's lying longitudinally within the uterus, the line is said to be aligned with the long axis of uterus. But somehow we have two presentations of longitudinal line, which is will be either cephalic or head or bridge that could be palpable at the pelvic inlet. So if neither is present, then it is an abnormal line. So in the case of transverse lie, the fetus must be lying across the uterus where long axis of fetus is at the right angle to the long axis of uterus with the head in the flank. And in transverse lie, fetal can be in different position horizontally. So position basically referring to the direction of fetal back as a denominator. So as you guys can see the pictures right here, we have two positions that are commonly happen in transverse lie. So in the case of oblique lie, the long axis of fetus form an acute angle with the head in one of the iliac fossa of the mother. So these two transverse and oblique lie have incidences about 1 in every 200 births. Okay, and for the unstable lie, the fetal lie and presentation constantly changing even beyond 36 weeks of gestation when it should have been stabilized. And also I would like to mention unstable lie has a few prominent complications such as cord entanglement, cord prolapse, and this can even lead to perinatal death. All right, for the next one is the risk factor of abnormal lie. So we divide it into two risk factor, group, which is maternal factor and also fetal factor. For maternal factor, the first one is multiple gestation. Multiple gestation is a pregnancy with more than one baby at a time. It could be twins pregnancy, or it could be triplet, it could be quadruplet, depends. And it would create a condition that prevent turning of the fetus inside the womb. And it is also one of the main cause of persistent transverse lie. Second risk factor is multiparity, usually due to previous pregnancy of the birth of the twins. So if you want to compare an nulliparous uterus in which no previous pregnancy has occurred, it could be a lot smaller than a multiparous uterus. So this factor provides circumstances that allow more room to turn, and this frequently resulting in an unstable or continually changing line. All right, for the third one is pelvic abnormalities, such as presence of pelvic uterine abnormalities. All right. Okay. Okay. The risk factor for number 4 is uterine abnormalities, such as Burkitt uterus, septic uterus. Maybe the presence of fibroid or scars due to surgery of uterus before this. So this condition can prevent turning of the fetus and may also cause persistent transverse lie in most of the cases. Okay, number 5 is polyhydramnios. It also provides circumstances that allow more room to turn, also resulting in unstable or continually changing line. And the last one is placenta previa. It is also a condition that prevents engagement of the fetus to the pelvic brain. Right, so for the fetal factor, number 1 is preterm labor or prematurity. So preterm labor is more commonly complicated by an abnormal lie than labor at full term. Second one is congenital malformation, for example, anencephaly. It is also a condition that prevents turning and may also cause a persistent transverse lie. We have hydrocephalus, small gestational age, and also some unknown reasons. All right. All right. Next is diagnosis of abnormal lie. The first one is we do history taking. So from the history taking finding, what you can do is basically assess pregnancy for risk factor. For example, all the risk factors that I have mentioned before, the parity, or any previous or current history of multiple pregnancy, or previous history of abnormal lie in presentation, or previous or current history of vaginal bleeding, include the onset, amounts, and also some of other factors to basically rule out placenta previa. And also we have to ask for history of decreased fetal movement. And also for abdominal examination, we do first inspection of the abdomen, and somehow we often, in this case, abdomen often appears asymmetrical. Second one is we do palpation. We look for symphysis fundal height. In this case, usually the SFH may be less or more than expected. When we do we call fundal palpation, no fetal pole in fundus pelvic inlet to be found. And also, in the case of oblique lie, the fetal head or buttocks may be in iliac fossa. So this is the finding of the abdominal palpation. Basically, just some point that I already mentioned before. And we do ultrasound scan to look for the fetus, and also to look for the placenta, the litters, and also the uterus if there's any abnormalities. That's all from me. Thank you.
Hi guys, am I audible?
Yes.
All right, thank you. Okay, Assalamualaikum and good evening to all. My name is Anis Atika. I will present regarding management of the abnormal lie. Okay, what you need to know for the management, if the patient come to you having a transverse or unstable lie before 37 weeks of gestation, there will be no action required unless the patient is already in labor. And also for before 37 weeks, ECV usually unjustified because the fetus usually will turn back to cephalic presentation. But if the patient presents with abnormal lie for at or more than 37 weeks, you need to admit the patient to antenatal ward, and then need to do daily observation for fetal lie, look out for necessity of active management to correct lie, provide immediate clinic assistance upon membrane rupture, look out for need of urgent management in the presence of fetal distress, cord prolapse, or cord presentation. Okay, next. Next. Okay, before. Okay, there will be two ways of management. First is expectant management, and the second one is active management. Okay. Next. Okay, for the expectant management, when the patient come and it's still okay, so first you need to daily observation for fetal lie, and when it's already in the ward, you because usually the fetus will be turned back, so you need to wait and for the 3 days. If the fetal already being to longitudinal lie, then the patient will be discharged. But then to continue assessment in 1 week time. After 1 week time, the patient need to come back to check for another assessment, and then wait for the spontaneous labor to occur. Then for the active management, there will be 3 active management. The first one is cesarean section. For the C-sec, is only indicated when the labor occurs when lie is already longitudinal. The second one is indicated if there are failure of the other 2 methods, which are if the ECV and stabilizing induction fail, then you proceed with C-sec. And then the third one, why you want to do C-sec? If the vaginal delivery is contraindicated, so you proceed with C-sec. And then ECV is external cephalic version, already mentioned by Hazim just now about the procedure. This one is performed where only the facilities permit immediate delivery. Then the third one is stabilizing induction. Stabilizing induction is performed only if the lie is stable and already in longitudinal lie, and also if the lie has been corrected by ECV method. Okay, next. Okay, I will briefly tell you and also emphasize again about ECV. As mentioned by Hazim just now, why the indication, why we need ECV?
if the patient have a breech presentation and also because of unstable lie. The contraindication, there will be two, absolute and relative. For the absolute, for example, like placenta previa, antepartum hemorrhage, ruptured membrane, significant fetal nullities, and also multiple pregnancy. This is absolute contraindication. For the relative, so this is like condition need to be, if want to do, need to be with caution, but it's not advisable lah. If they have a previous scar, macrosomic baby, any suspected fetal compromise, severe proteinuria hypertension, obesity, and also intrauterine growth retardation. Okay, next. Okay, these are the procedure. Okay, if the patient need to be corrected by ECV, the lie, the patient already need to be prepared as it's going to having a operation. So the patient need to fasted overnight, empty bladder. So if want to do ECV, already need to be prepared as want to go to OT, like need to go to for a C-side. Okay, indeed, if you want to do ECV, GSS need to be available. OT need to be standby already if want to do ECV. After that, need to monitor maternal heart rate. ECV only need to be performed not more than 2 attempts and no longer than 10 minutes. For the recommendation of technique, forward somersault when fetal bed is downwards, and if fetal bed is upwards, so it recommend to do backward somersault. After that, after the procedure, need to check fetal heart rate for 20 minutes. And then after the ECV is done successfully, need to observe for the pervaginal bleeding or spontaneous rupture of membrane before departure from labor suite. And then if success, need to continue observation for the patient overnight. If it's okay, then can be discharged, and then also need to be continued assessment in a week time. Okay, next. Okay, for stabilizing induction, this one is carried out for the patient who have unstable lie but already been corrected the lie by ECV method, or spontaneously baby has turns to longitudinal lie with cephalic presentation. For the precautions to do this method, it's done early in the morning by experienced medical personnel. From what I read, why it's done in the morning because of it's just because of the early start of the shift of the ward and then the availability of the staff. Doctor, is there any other reason other than that? And also there's by research stated that if done in the morning, it will be lead to less complicated birth.
No, usually you try to, I mean, it's done in control situation when it's preferably done during daytime, because most of the staff are, I mean, senior people is available, rather than during at night when limited staff is available. If let's say it turn out to have problem, because when you do stabilizing induction, one of the complication is if you're not doing it properly, you may end up with cord prolapse. Okay, because the presenting part is not well attached to the because the session is high, so the likely to cord will come out. When you drain the liquor, the cord may come out with the liquor. So that's going to be an emergency situation. That's why we prefer it to be done during daytime when most of the people are available, and probably the senior kalau in our OT situation, the specialist is around usually during daytime rather than nighttime. Okay.
Okay.
Mainly it's because we want it to be done during when the more experienced people are around during daytime, and we try to avoid complication during later of the day. For example, kalau you do the procedure noon time ataupun near the office hour time, probably your specialist ataupun they already gone back.
Okay. All right. Thank you, Doctor.
Anybody wants to ask any question, you can just ask lah. If you not apa, you're not sure ataupun you're not understand. Okay, usually stabilizing induction ni we do it like what she said, like what you said just now. All right. You do it after you have stabilized the presentation into cephalate, right? But the presenting part not yet engaged, meaning the station is still high. When you do the vaginal examination, the os is open. Okay, there's os dilatation, but the presenting part still high. So what you do is when you do stabilizing induction, you just make a small nick at the membrane and you try to drain out the liqua, hoping that with the slow drainage, when the liqua is much reduced, the presenting part slowly engage into the pelvic cavity. Okay.
All right. Thank you, Doctor. Okay, and then as this method will have a risk of cord prolapse, that's why OT need to be standby. Also, the patient need to keep her bladder empty, then need to continue CTG monitoring, and then there's the experienced person need to watch on patient to confirm that continuing cephalic presentation, and then need to monitor uterine contraction. Okay, next. And these are the steps that already mentioned by Doctor just now. Firstly, we need to do vaginal examination to make sure there is no gross pelvic contracture, and then the cervix is at least 2 centimeter dilated. Must make sure there is absence of cord presentation. And then if cervix favorable at using Bishop score, then proceed with vaginal delivery. Need to make sure that it's in longitudinal lie and cephalic presentation. Need to start IV infusion of oxytocin as described with induction of labor to simulate the contraction. And once regular uterine contraction are established, ARM is artificial rupture membrane is done with an experienced assistant stabilizing the fetal head abdominally into the pelvis. There's experienced staff stabilize the fetal head to make sure it is in the pelvis. And then the amniotomy need to be performed between contraction because there is a high possibility of risk of amniotic fluid embolism, and make sure it will be with a slow release of liquor, like mentioned by Doctor just now. And as the head is allowed to go into pelvis and need to observe it stay there. If stay, then the procedure is success. And then VEs need to be done again to exclude cord prolapse. And if the head shift back, then procedure is failed. So immediate lower segment C-sec need to be done. Okay, next. Okay, this algorithm to make you understand better. So if admit the patient at 37 weeks for the expected management, if the fetal turns back into longitudinal lie within 3 days, then the patient can be discharged to their home, and then come back if there is a spontaneous labor. We'll do stabilizing induction, but if stabilizing induction fail, need to do zigzags. And if success, okay, can do SVD normally. And then for active management, start with ECV. If fail, then immediately do CSAC. If success, can go to home, then wait for a while, then the patient have a sign of labor. We do spontaneous labor, and then we'll do stabilizing induction to stabilize the head into the pelvis. And if fail, again do CSAC. If success, can do SVD normally. Okay, I think that's all from me. Okay. This is just like a revision, not revision, like summary for transverse oblique. If more than 37 weeks, ultrasound to find the causes of it, and if not stabilized by 41 weeks, need to do elective CSAC lah. Okay, I think that's all from me. This is our reference.
Can you go back to your slide just now? Okay, it's because you wrote there, if not stabilized by 41 week, or if pelvic obstructed elective seizure. Usually you do not wait until 41 weeks. By 37, by 38 weeks, usually when you saw them around 36, 37, you assess the patient. Why is the patient is transverse or oblique lie? Okay, you roll out all the possible causes like placenta, especially placenta previa, or fetal causes or uterine causes. Then if by 38, you give them elective elective date for cesarean section. Okay, if the patient come with unstable lie, you still admit them and see if the baby changing position and all. If the baby keep changing the position within 24 hours, I mean, or you observe them within 3 days, if the baby not in cephalic ataupun keep changing position, you still give them appointment for, I mean, elective date for cesarean section. Okay, usually you do not wait until 41 weeks. That is, I would say, apa, I mean, in other situation, if let's say patient come initially she was in cephalic presentation, but when you saw them around 40 weeks, they're in abnormal presentation, then you give them date. Usually you do not wait until 41 weeks because all clinic case, patient yang datang every regular antenatal checkup, we assess their lie ataupun presentation. Towards term, if any abnormal presentation, usually you already have a plan for them. Either if breach, kalau if suitable for ECV, you do ECV. If not, then you give them elective date. Right? Only certain cases isolated, kita kata patient was initially all the while cephalic presentation, but once they come for delivery noted to have abnormal lie ataupun abnormal presentation, then you just give them a date for Caesar. Usually you do not wait until post EDD. Post EDD because EDD at 40 weeks. If by 41 weeks it's already EDD 7 days. Usually you do not wait until post EDD. Understood?
Yes, thank you, Doctor.
Okay. Any more questions?
Doctor, what is the reason need to cap the bladder empty?
For what? Before any procedure, I mean, you yourself, if you have full bladder, don't you feel uncomfortable
No.
with and then you see the side of the bladder. The bladder is if let's say you want to do a procedure, if you look back at the anatomical bladder anatomical, it next to the uterus, right? The in cephalic presentation, if the bladder is too full, how can the head going in? It will slightly obstruct the upper, or even if you want to if you look at the slide before, how do you perform ECV? Because you need to hold the head and you need to hold the buttock. Okay.
Yes.
So if you pressing, how can you hold the buttock? Buttock is down there, right? If you look at the, can somebody show the slide just now? Okay, if there's a full bladder, how can you hold the hole? We call it pole. Pole tu kalau pole in singleton kita kata two pole, which is head and buttock. P-O-L-E. Okay. Usually in clinical, later on when you come back, we revise this again. Okay. Usually when you comment about presentation, why do you say this singleton? You said because I can feel two pole, which is buttock and the head lah. Yeah. Okay. Kalau in multiple pregnancy, you said what makes you say this is twin ataupun multiple pregnancy, because I can feel more than two pole. We call it pole. Understand? So when you if before you do the maneuver, okay, because somebody show me I'm not sure which presenter tadi yang dia tunjuk ECV tu. Can you show me? Okay, so you do the maneuver. We call it either somersault, forward somersault or backward somersault. Right, because you turn the baby. Okay, you need to hold the two pole, which is the buttock and the head. Okay, you can surf any video, you can see how do they do it. Right, if you do it with the full bladder, how can you hold the pole? Because the bladder is in front. It's going to be very difficult and very uncomfortable for the mother. Okay, that's why you need to empty the patient's bladder first. Understand?
Yes.
Any other questions?
Doctor, is the ECV procedure have any complication?
Of course, it's not, any procedure is not without complication, right? But the complication is less. I mean, I would say it's minor if you choose the patient correctly. That's why if you look back, ECV, dia ada indication, dia ada contraindication. Okay, because you try to minimize the complication from the ECV itself. Do you have the complication? Did you list out? You don't have the slide to show the complication from the ECV. Of course, the ECV ada some minor complication if you're not doing it properly or you not being extra careful ataupun you select a proper patient. That's why if you look at here, macam we try to avoid, of course lah, it's only can be done in singleton, multiple mana boleh, because you don't have space pun to turn if you have so many pole kan, ada baby kan, ataupun more than one baby, you don't have space to turn the baby. You cannot do in Laikwa, ini pun I mean, it's not that kita kata your contraindication pun not so tak berapa lengkap. I would say sebab dia ada banyak lagi in term of Laikwa. If Laikwa is reduced, you cannot do. You ada mention about Laikwa. What about the baby, size of the baby? Kalau baby tu IUGR, you cannot do. If the baby is too big ataupun macrosomic, you also it's not a suitable patient to do. Right, of course, fetal anomaly also not you're not going to do, especially previa. Of course lah, it's memang contraindication, because if you turn pun you cannot deliver vaginally because it's previa. Alright, patient with previous scar also not suitable for ECV because you're worried of scar rupture. Alright, you manipulate the uterus, end up with scar dehiscent and ruptured. Okay, from the previous scar, because usually scar on the uterus it's not strong, all right, because it's when it's healed it become fibrotic tissue. Fibrotic tissue is not strong tissue, right? With sometimes with that kind of manipulation from the ECV, the scar can be open up lah, maksudnya fractured, right? Of course, complication, if you read properly, there's a few, but I would say if you choose patient carefully, you can minimize the complication. All right. Antaranya is abruptio, all right, fetal bradycardia, all right, after the procedure, right. Total breech extraction. Okay, total breech extraction. It's only done for in delivering of twin pregnancy in second twin. Maksudnya if when you mention the total breech extraction ni is if you're delivering the twin baby, okay, the first baby has come out cephalic, right, and the second twin is still inside in breech presentation. So total breech extraction means you catch the lower limb or the legs and then you extract. Okay, that is total breech extraction. It's only be done in delivering second twin. Okay, not in singleton pregnancy breech. It's totally contraindication ataupun totally nobody do that. We in singleton breech presentation we only do we call it assisted breech delivery. Assisted breech delivery meaning you don't pull the baby, you let the baby delivery. You only help with a certain maneuver to ease the delivery, not extraction. Extraction means you pull. Okay. Painful. I would say it's very uncomfortable. Right? Very uncomfortable. That's why before the procedure, okay, not only you need to prepare the patient as she's going for OT, but you need to remind the patient that the procedure is uncomfortable, right? All right, thank you. If no more question, all right,
Doctor,
thanks.
I have question. What if the placenta is not located at the upper part of the uterus? Is it can do ECV?
What do you mean upper part? Upper part anterior ke posterior ke or fundal?
The placenta is not located at normally kan dekat upper uterus.
Upper segment. Upper segment it can be anterior, it can be posterior. Of course kalau you kata lower segment tu is already previa. Faham tak? Upper segment it can be anterior. Of course kita kata kalau if you look at the diagram, kalau the placenta is uterus, you imagine the uterus, there's a kalau daripada depan perut dia tu is placenta dulu and then the belakang placenta is the baby. So it's going to be difficult for you to hold the pole. Because in ECV you kena pegang dia punya kepala and you kena pegang dia punya batok and then you turn into somersault, either backward somersault or anterior somersault. So kalau ada placenta dekat situ, it's going to be a little bit difficult. A little bit difficult because you cannot hold the baby properly.
Alright, doctor.
But not necessarily kita kata it's going to be fail. Cuma maybe the chances mungkin I would say it's a little bit difficult because you cannot hold the baby properly. You can hold and then because it's placenta, the bulk of placenta. So it's going to be apa? Macam ada gap lah in between tu.
Okay, doctor. Thank you.
Alright. Okay, that's all. Thank you.